And the chairpersons for the talk are, I request all the chairpersons to come over the dais. Dr. Alok Mishra sir, past President AMA and Senior Gastroenterologist Dr. City. Dr. Manoj Mathur sir, Professor in Department of Medicine of Motilal Nehru Medical College, Prayagraj and ex-Honorary Secretary of AMA. Dr. Piyush Saxena, Professor in Department of Cardiology of Motilal Nehru Medical College, Prayagraj. We welcome all the chairpersons on the dais. And now I request Speaker of the talk, Dr. Harshad, to please come over the dais, and we welcome sir on the dais. Dr. Harshad sir. I request chairpersons to introduce our speaker of the talk today.
Welcome. Dr. Harshad Devarbhavi is a professor of St. John's Medical College, Bangalore. He has a basic interest in the drug-induced liver injury, and is the one person whom we always look for any question regarding the drug-induced liver injury. I request Professor to please start his deliberation.
Thank you very much for the kind introduction. I would like to first thank Dr. Anupa as well as Dr. Rohit and the organizing team for inviting me here. It's been a real pleasure to come to Prayagraj. So my task today is to talk on drug-induced liver injury or drug-induced liver disease. And this is a very common topic, very important, but we'll try to find out the reasons why it is so important. From the regulatory point of view, it leads to a lot of drug withdrawal. People invest millions of dollars and then it gets withdrawn. And it gets withdrawn because of the commonest cause is either cardiotoxicity or hepatotoxicity. So a lot of attrition, people spend billions for a molecule and you find that the drug is dead when you have hepatotoxicity. Doctors are exposed to a liability list, many times very unfairly, because most drug-induced liver injury is idiosyncratic. And therefore patients, of course, there's significant morbidity and mortality, especially with regard to anti-TB drugs. And TB is a very eminently, very easily treatable disease, but many patients develop side effects and unfortunately die due to hepatotoxicity. Now, because of the surging tide of diabetes as well as obesity, you'll find there are many patients who have abnormal AST and ALT. So there's a definition or various points for diagnosis of drug-induced liver injury, which means AST, ALT more than 5 times the upper limit of normal without symptoms. Or if you have symptoms and the ASTs or ALT is more than 3 times or bilirubin is 2 times, it's drug-induced liver injury. Because there are no diagnostic markers, you have to rule out a lot of competing causes like acute viral hepatitis as well as obstructive jaundice. Now, the reason hepatocellular jaundice or disease resulting in jaundice is important with regard to drugs when compared to viral hepatitis is shown in the next slide. You find if you have jaundice, any patient with drug-induced liver injury comes to you with jaundice, the mortality is 10%. Straight away you can see him, regardless of whether the bilirubin is 2, 3 or even 20. Whereas if you have a patient who has jaundice and viral hepatitis, you see the mortality is so low, just 0.2%. And this law that there's increased morbidity in patients who are hepatocellular DILI, the drug-induced liver injury, is known as Hy's law. Now, diagnosis DILI, as I said, has no diagnostic biomarker, so it's challenging. So it's an underappreciated cause of liver disease. The clinical features I'll show you the next slide mimics all forms of liver disease, and there's no pathognomonic test to diagnose liver injury. Now on the left side you'll find a lot of phenotypes that any hepatologist or even general medicine person will see. You have patients with acute hepatitis, you have patients with cholestatic hepatitis, you have patients just sometimes enzyme elevation without jaundice, and some patients with the cholestasis. And the common causes for all these diseases are viruses, hepatitis A and B, cholangitis. Even AST, ALT line elevation can be seen in the routine infectious diseases that most of you see. There is typhoid fever, leptospirosis as well as dengue. Your CVD obstruction is the commonest cause for cholestasis. As I'll come to the next slide, you'll find that almost all of these can be produced by a drug. Almost all of these. And more importantly, two important points I want to show, and that is one, with regard to acute hepatitis due to anti-TB drugs and enzyme elevation without jaundice in patients who receive heparin. For example, in a patient who is in the ICU, you see raised AST/ALT, it is because of heparin, and sometimes even after 4 or 5 tablets of paracetamol. Now, especially with regard to I and HO, so we say these are heparins and paracetamol, the drugs that bark, they do not bite, whereas the drugs that are commonly cause hepatotoxicity, the anti-TB drugs, are not just that they bark, but they also bite very, very bitterly. Now, because no diagnostic markers, then you have causality assessment. So on the right is the RUCAM, Russell-Luklev causality assessment, and then give a few points as to when did they first take a drug, when did it start, what happened to the course, have you ruled out concomitant viral hepatitis, previous information where the drug has produced AST/ALT elevation or not, and sometimes re-challenge, and you give a certain score, and totaling the certain score, you can either say it is highly probable, probable, or definite or unlikely. Now, this is very subjective. So 2 years ago, the Americans came up with American and Europeans came up what is called a RECAM score. It is revised electronic causality assessment method, and I've listed the website there. It's very easy. It removes the subject of the element of subjectivity and makes it more objective. Now, in the hepatotoxic spectrum, you'll find in the base here, you'll find lots of patients with AST/ALT. Generally, does not cause any problem. But as you rise in the ladder, you find they become symptomatic. And towards the top, you find that patients have acute liver injury without coagulopathy, and the topmost is reserved for those patients who develop fulminant liver failure, acute liver failure. But in our condition, especially, you have to look at background noises. And I'll show you the slide, there's one slide from All India Institute of Medical Sciences, that many patients with jaundice actually have viral hepatitis. So in one series from All India Institute of Medical Sciences, 14.7% of patients who are receiving anti-TB drugs actually had viral hepatitis E as well as viral hepatitis B. Now, regarding the types of bili, you can divide them into direct and indirect, as well as indirect as well as idiosyncratic. Now, with regard to direct, there is a classic example for direct hepatotoxicity is paracetamol poisoning. Fortunately, it's very low in our country, but very, very common cause of hepatotoxicity both in Europe as well as in USA. In the south, instead of paracetamol, is yellow phosphorus poisoning. So the dose that one's own synthesis, or it's one's own genetic constitution that is responsible for drug-induced liver injury. It's not the drug that is the culprit, but the person with the genetic constitution is the culprit. It's very rare. You see that it's 1 in 10,000, sometimes 1 in a lakh of individuals. The latency is very short. It's a few weeks, few days to a few weeks. And there are many implicated drugs that the commonest one with regard to our country is anti-TB drugs and anti-epileptic drugs. A new one that has come up recently in the last 4 or 5 years is known as indirect. The per se, the drug does not produce liver injury, but it alters the immune system like immune checkpoint inhibitors or monoclonal antibodies or protein kinase inhibitors or even high-dose corticosteroid. So it's what the does than what it is that produces immune-related or drug-induced liver injury. And I like this slide very much from attributed to Wills Maddrey. Most drugs that cause drug-induced liver injury have signatures. It's just that sometimes the signatures are illegible. So if you look at it very carefully, every drug, for example, has a classic signature. And if you miss the signature, you have lost the plot. But if you can identify the signature, then it's very easy to make a diagnosis. Now, the signature could be the strength of or height of rise of AST/ALT, the chronological latency period, the clinical histological, and sometimes the combination of both. And ATT has 4 signatures. You find the commonest one is there is transient. 20% of patients with ATT have raised AST and ALT elevation about 3 times, 4 times, and some even 5 times. You continue the drug, it settles down. So this is known as adaptation. This is the classic signature. And 20%. I don't think there's any other drug that produces this kind of signature. Then you have an idiosyncratic, which I mentioned, that 1 in out of 10,000 patients develop severe liver injury. Immunoallergic is in patients develop DRESS syndrome with skin rash and lymphadenopathy and eosinophilia. ATT is the second commonest cause of DRESS syndrome. And finally, many of you see, it's about 10 or 15% of patients who are on anti-TB drugs, predominantly unconjugated hyperbilirubinemia. The AST/ALT is not elevated much, but the bilirubin is markedly elevated, sometimes 10, 15, and even 20. It's because of the blockage of the biliary transporters that produces increased bilirubin. And Rett syndrome, again, classic features of eosinophilia and skin rashes along with hepatitis produces by all the first-line anticonvulsant agents. Yeah, so this is a publication that's just ahead of print, and you'll find that many of these transporters, whereas influx transporters as well as influx transporters, all of these transporters can sometimes get blocked because of a drug. And I show in the next slide, all these drugs that are listed can either block the influx transporters or the exflux transporter. And once they block the transporter, then you have jaundice. What happens when the transporters are blocked is that bile salts accumulate in the hepatocytes. And that, bile salts are very toxigenic. There's a detergent effect, and that produces hepatotoxicity. Most patients who have a blockage of these transporters actually have hepatocellular disease rather than cholestatic disease. So you'll find mild rise of AST, ALT elevation in these patients. Now coming to the causes. The top 5 causes in India are anti-TB drug, complementary medicines, and complementary and alternative medicines, anti-epileptic drugs, the first line anti-epileptic drugs that we still use, antimicrobials, and our last one is non-steroidal anti-inflammatory drug. What about China? The top 2 are complementary medicine or complementary Chinese medicine as they call them. The second one is anti-TB drug. In the West, it's antimicrobial, and the most common antimicrobial is augmentin in the West, followed by dietary and herbal supplements. So dietary and herbal supplements all over the world either are the first commonest cause of drug-induced liver injury or the second commonest cause. So next part of my talk, I'll talk on 2 different diseases, the anti-TB drug-induced liver injury and complementary medicine-induced liver injury. Now you find that India has the largest burden of tuberculosis. We have about 26% of all world's tuberculosis in our country. Men more than women develop tuberculosis. Unfortunately, women more than men tend to develop more hepatotoxicity and also mortality for unknown reasons. So with anti-TB incidence approximately is about 5-6%, but can go up to 10% and even 12% depending on what kind of definition that you use. Now, for example, anti-TB drug is the commonest cause of hepatotoxicity in this country, as I have listed before. It is the commonest cause of drug-induced acute liver failure. It's not paracetamol. Paracetamol is the commonest cause in the Western countries. But in our country, unfortunately, anti-TB drug is the most commonest cause of acute liver failure. And again, in the condition known as acute and chronic liver failure, drug-induced liver injury due to anti-TB drug is the commonest cause. Now, generally, anti-TB drug-induced liver injury occurs in the first 2 months, or perhaps in the first 3 or 4 weeks. So, as I said, each drug has a signature. Anti-TB drugs comes in the first 3, 4 or 5 weeks, although it can come throughout the course of therapy, but most commonly it comes in the first 3 or 4 weeks. Now, most patients, when they develop jaundice, whilst they are on anti-TB drugs, you make a default diagnosis of anti-TB drug-induced liver injury. I think this is wrong. Because this study that I mentioned briefly earlier from All Indian Institute of Medical Sciences, you find that 14.7% of patients who had jaundice as well as what looked like hepatotoxicity actually had hepatitis E as well as hepatitis A infection. And how do you distinguish between the two? There are certain clues. If there's a delayed latency, it comes about 2 months, 3 months later, then probably it's viral hepatitis. And also with viral hepatitis, the AST and the ALT is in several thousands. Whereas with anti-TB drug-induced liver injury, it's in a few hundred. Now, as I mentioned, 10% of patients, or sometimes even more, develop this adaptation. About 4% develop severe liver disease, 1% have developed acute liver failure. As you will see, many of these drugs were manufactured or discovered, 70, 80 years ago, just after the World War II. If these same anti-TB drugs had to pass through regulatory authorities today, not one except ethambutol would have passed the regulatory authorities. None would have passed. So why do we still use the drug? Because we have no other alternatives. Fortunately, for multi-drug resistant tuberculosis, you find that this BPAL regime, that bedaquiline, protiminate, as well as linezolid, produces very little hepatotoxicity, less than 1%. So, and then because these are such safe drugs, that the FDA has increased the levels at which you can stop to about 8 times. With regular anti-TB drugs, you have to stop after 5 times AST and ALT, but with the second line drugs, you need to go up to 8 times because it's such a safe drug. Now, current recommendations regarding monitoring of LFT and ATD, you have either clinical or laboratory monitoring. I'll just tell you about what we in the Asia Pacific regions have suggested. Do we need to baseline LFT? The answer is yes, at least once. But if the baseline LFT is normal, then you don't have to do it. But do we need to do baseline viral markers? The answer is yes, at least hepatitis B and HIV. Now, do we monitor if the baseline is normal? LFT costs money, so we don't monitor them unless their baseline is abnormal. And then, if somebody develops anti-TB drug or baseline is abnormal, then you need to do it more frequently, and you can choose how often you want to do it. And if somebody really has a liver disease, for example, non-alcoholic fatty liver disease, you need to do it more frequently. After the patient has developed anti-TB drug-induced liver injury, how do you stop and how do you monitor them? Now, stopping anti-TB drug-induced liver injury, yes, of course, we have to stop except for ethambutol. And when do we start? We can start when the AST/ATL comes to less than 2 times the upper limit of normal, bilirubin is 1.5 times. And when do we restart? And most societies, our societies from Asia Pacific region, as well as both American as well as the British, have said that rifampicin is the least hepatotoxic among all these drugs. So we start with rifampicin, and after about a week, we can start with INH and gradually stagger the dose and give it. So first rifampicin followed by INH is the way to go. And if somebody has developed ATK hepatitis, we generally don't give pyrazinamide again. Now, how often do we monitor? Because these patients have got varied degrees of liver injury, we can monitor them as frequently as possible, perhaps once in 3 days or once in 7 days. Now, just one slide about severity or treatment of TB in patients who have cirrhosis. Again, this is a deadly disease, as I said, once you develop hepatotoxicity. And these drugs are toxic. The liver really, they can't handle this. So there is a simplistic way of treating this. Somebody has got child C, you don't give these first-line drugs at all, except for ethambutol. If somebody has child B, you only give rifampicin, which is the least hepatotoxic drug. And if somebody has child A, then you either can give the rifampicin with or without ethambutol along with along with ethambutol. You can always prolong the duration of treatment when you give these drugs. And what about new remedies? The answer is there have been some studies about N-acetylcysteine, which has been used both in treatment as well as in prevention. And I'll show you 2 studies. This is a study from South Africa, where the randomized controlled trial of intravenous N-acetylcysteine in the management of ATT drug-induced liver injury. 102 patients had a significant liver disease. You can see EAT is 460, bilirubin is 3. 11% of patients developed acute liver failure and 14% died. So what they did is they compared it with the placebo, and although they did not find the time to EAT normalization, 7.5 NAC group and placebo 8 group, they found that the time to discharge from the hospital was significantly shorter in patients who received N-acetylcysteine compared to those who had received placebo. Now, efficacy of N-acetylcysteine to prevent DILI. Can you just prevent DILI? Because many patients have risk markers or risk factors such as old age, comorbidities, renal failure, alcohol. The answer is yes, many people have. We have Indian study as well as some studies. This is a study from Taiwan, where they, after 82 patients, and you'll see from these orange bars compared to the green bars, that whoever received N-acetylcysteine had a lower prevalence of hepatitis, although they did not reach statistical significance. But when they looked at, again, subdivided them into whether patients had slow escalator status. You know, for example, many Indians, almost 60 to 65% of we Indians are slow escalator status. So because we metabolize INH very slowly, a lot of toxic metabolites accumulate in the blood, which is responsible for hepatotoxicity. So when you divide them into whether they are slow escalator status or not, you'll find once you give N-acetylcysteine, then you hardly ever develop hepatotoxicity than when you do not give them. The last part of my talk is on traditional and complementary medicine. You'll notice that despite even the technologically well-advanced countries in the world still tend to use traditional and complementary medicine. Chinese medicine is the standard of care in patients in China. Singapore, such an advanced country, 71% of their diseases are due to traditional medicine. South Korea, 70%. In India, although 90% use traditional medicine, its contribution is about 14%. Now, I've just listed the top drugs causing drug-induced liver injury across different countries, across Taiwan, China, India, South America, and USA. And I've highlighted a few. And the few ones in China is polygonal multiforum Tusanchi. Tusanchi produces classically what's known as hepatic sinusoidal obstruction syndrome. In India, it's Giloy, that's commonly known as, and that Pinofora cordifolia. It produces something like immune or drug-induced autoimmune-like hepatitis, and especially during the COVID and post-COVID era, we had plenty of cases of Giloy-induced hepatotoxicity, followed by ashwagandha in the West as well as turmeric, and I have a slide of turmeric coming up. So here is a 54-year-old lady who has rheumatoid arthritis, presents with jaundice and significant AST-ALT elevation. Again, you do all the viral markers, they are negative. You do a liver biopsy which shows autoimmune hepatitis, but when you probe further, all of them initially denied that they take complementary medicine. You find that she took 56 drugs which had 56 ingredients in the form of liquids. These are the form. She took liquids, tablets, different colored tablets, solutions, 56, and you find this almost 70 odd constituents. But I highlighted the ones that are known to produce drug-induced liver injury, and that include ashwagandha as well as guduchi or Pinospora cordifolia. Produces what classically a drug-induced autoimmune like hepatitis. We need to treat these patients with steroids just for a finite period of time, and then lo and behold, after you stop the drug, they are okay. Now there were drugs. These were published during the COVID era, and I have just showed two headlines here. But then I again summarized the entire Indian data for Pinospora cordifolia induced liver injury. The first publication which raised a lot of storm, including comments from the Ministry of Health from after Abha Nagral published this paper in Journal of Clinical Experimental Pathology. Only 6 patients. This was followed by Phillips as well as Kulkarni's article on 43 patients in hepatology communication. And then Akash Shukla's, which was not published yet, but it's in the abstract form of 55 patients. And here I have summarized the patients here. So you find 104 patients. As I said, drug-induced liver injury unfortunately affects females more than males. And here you have females more than males. Significant liver disease, bilirubin more than 13. You find ASTL again very significant, more than 10-15 times. And again, at least in about 2/3 of patients, it produces autoimmune hepatitis-like marker, including raised or ANE, anti-smooth muscle antibody, and rarely LKM. So this drug classically produces what looks like drug-induced autoimmune-like hepatitis. Now, finally coming to turmeric. A lot of controversy about turmeric, and as mentioned here, the country of Italy prohibited all health claims and issued warning about taking turmeric. And I'll tell you why. There have been few cases or case reports reported from turmeric. This is the acute liver injury that led to liver failure from Italy in Tuscany, and then a series of 10 patients published in the US from the drug-induced liver injury network. Now we take tons and tons of turmeric. Turmeric doesn't get absorbed the way we think it is. So how does turmeric really produce hepatotoxicity? The answer is, as I said, turmeric has poor absorption and bioavailability. It has low solubility. Even the little that's absorbed and metabolized faster and is eliminated. Now what these pharmaceutical companies or people who manufacture these have done is, they have added or spiked it with black pepper, that's piperine. And once you spike it with black pepper, the absorption of curcumin in this terminal increases to significant level. Or they make this what is known as liposomal curcumin, which is a small molecule which gets absorbed much faster, or curcumin nanoparticles, and again combined curcumin and piperine nanoparticles. So when you make it in nanoparticle form, they tend to get absorbed much faster and produce toxicity much higher. So this is why turmeric produces hepatotoxicity. But in the turmeric that we all use daily in our food, that is non-toxic. So if these patients take these drugs in the capsule form, and it's a human tendency, if it can take one tablet and it produces antioxidation effect, people tend to take it in much larger amounts for a prolonged duration of time. So these are the forms that generally produce hepatotoxicity. So how do we manage drug-induced liver injury? The important thing is to recognize. Most patients or doctors don't recognize. Once you have recognized that it's due to drug, you stop the drug, most patients become better. Consider the possibility of DILI as a differential diagnosis, any liver disease that present, any liver disease, whether acute hepatitis, cholestasis with significant itching, non-alcoholic fatty liver disease, sinusoidal obstruction, please ask about drugs. They all become worse and then to become better because it takes some time for the drug effect to wear off. And what about antidotes? Antidotes, there are a few, as I said. N-acetylcysteine is an antidote for paracetamol poisoning, but it emerges that N-acetylcysteine is also the antidote for acute liver failure due to anti-TB drug as well as for anti-TB drug-induced liver injury. L-carnitine for valproate, I didn't talk about it. Cholestyramine for leflunomide hepatotoxicity. When patients have hypersensitivity features with Rett syndrome, skin itching, lymphadenopathy as well as eosinophilia, whether it's anti-TB drugs or any other drugs, including anti-epileptic drugs, please give them please give them steroids, and please continue the steroids for at least 2, 3, or sometimes 4 weeks. If there's cholestasis, use UDCA, and again some people have used both UDCA as well as steroids. So finally, if you have a patient with drug-induced liver injury, you look at first rule out all common causes including viral hepatitis and obstruction. And if they're asymptomatic, just leave them alone. Most of them will do well. If they're asymptomatic, but the AST ALT more than 5 times, even 8 times, then you need to stop the drug, regardless which drug it is. If they're symptomatic and jaundice, and I mentioned to you, jaundice is a very dreaded sign, clearly you need to stop the drug. And then perhaps if it is ATT, you can give them N-acetylcysteine. If there's hypersensitivity features or drugs that produce drug-induced autoimmune like hepatitis, you need to give them stop the drug, of course, and give them steroids. Thank you.
Thank you, sir, for such an elaborate and comprehensive overview of drug-induced liver injury. Sir, in the ICU setting, we are using multiple antibiotics and their combinations in these serious patients. So, which of the group of the antibiotics are to be avoided and the combinations we should restrict using regarding drug-induced liver injury?
If a person requires an antibiotic, you need to use what an antibiotic you think is due. And many of us, I didn't mention about genetics. I think genetics, as I just mentioned that idiosyncrasy, so genetics plays a big role in this with regard to drug-induced liver injury. Many of the genetics that are known to be associated with this are less common in this country. That's why you find that augmentin-induced drug-induced liver injury, ciprofloxacin-induced drug-induced liver injury are much less here than elsewhere. But if you have used these drugs only for a finite period of time, that's about 7 days, 14 days, either in the wards or in the ICU, then you can generally get away with it. And as I mentioned again, many of these patients have comorbidities. They are in the ICUs. That itself, for example, produces AST elevation. In that case, I think you still need to continue the drug. But the moment you have jaundice, you need to stop the drug. But you have to, for a specific answer, which antibiotic you have to be careful. I think you can take all antibiotics. They come through regulatory authorities. But tuberculosis, I think, is one important one. If patients do not have clear-cut tuberculosis, for God's sake, don't give them the anti-TB drug. You find those patients who develop disease never required the drug in the first place. So those patients who develop severe disease never required the drug in the first place. And especially these are immune competent and women in the younger age. So TB, I think, would be more careful rather than any other drug.
Some other concerns.
We have lots of questions.
Yeah.
Yes, please.
It was a very good talk, particularly on ATT-induced hepatotoxicity. I'm a pulmonologist. A very basic question. Is there any role of excessive carbohydrate diet in prevention or treatment of ATT-induced hepatotoxicity?
The quick answer is I do not know, and I don't think so. Because I've just tried reading before this almost everything that mentioned about ATT, but carbohydrate diet I did not see. Maybe you can, if you have, you can tell me.
You said you don't think so. So what's the theory behind that you don't think so?
The carbohydrate diet?
Yeah.
Because I think I don't know how it fits in mechanistically. That's why I said I don't think so. And carbohydrate, most Indians, especially South Indians, the carbohydrate intake is about 60 to 60.
There's no literature to suggest, Dr. Shukla.
You're saying carbohydrate causing hepatotoxicity?
No.
Diet.
Okay, yes, that's what.
There's no literature.
Many times what happens that when the patient develops the ATT-induced hepatotoxicity, we do prescribe high glucose. We do oral intake as well as intravenous intake. And that helps also. Well, it has been perceived in a clinical practice, but I don't know is there any literature about it or not?
I'm not aware of it.
Okay, thank you.
Just request
Dr. Shukla, the concept of high glucose diet is in tradition in our country. Whenever there is jaundice, give the glucose diet. But there is no scientific data to show that high glucose diet, even acute viral hepatitis or any type of hepatitis, improves the outcome. Only thing is, protein might may be helpful, but a pure glucose-rich diet, we have not got any data, any scientific literature that it helps or prevents any type of drug-induced injury or pure viral hepatitis injury.
So doesn't it say that there should be a study for this?
We can do that.
Thank you. Thank you.
So my question is, nowadays viral fever is very common, and most of such patient has
सर आवाज नहीं आ रही है, थोड़ा सा माइक पास
most of such patient has high liver enzymes, and we are using paracetamol in such patients. What is your practice? How much paracetamol should be given? It should be given or not?
Yeah, the standard doses of paracetamol are okay. When I say standard doses, how much? I think more than 2 to 4 grams is quite okay. And you hardly ever need to cross 2 to 4 grams. And many people do not even know that even patients who have cirrhosis, you still can give them 2 grams. That's 500 milligram, 4 times, even in cirrhosis. So you can clearly go for up to 4 grams in patients who have fever and altered enzymes, for example, when they have viral fever due to dengue and all these different diseases.
So what dose is
No, as I said, 2 to 4 grams clearly you can give them. The toxicity starts when you give them more than 8 grams, 8 to 10 grams. 8 to 10 grams as a therapeutic venture you hardly ever give. You know? Even if you want to give those IV paracetamol, which I do not like, IV paracetamol, it has 1 gram. And even if you give it 4 times a day, you still have not crossed the thresholds of hepatotoxicity.
Sir, do you recommend to start prophylaxis and anastatic in cases of ATD?
That's a very interesting point, and some of my colleagues and me as at some point in patients who have risk factors like old age, chronic renal failure, and some comorbidity, have actually done that. N-acetylcysteine is at the end of it you want a live patient, you don't want a dead patient. So N-acetylcysteine is very cheap, you give it at 600 milligram BID, and just give it in these patients who have tuberculosis with 4 drugs.
Do you recommend in all patients?
Not all patients.
You should give prophylaxis
No,
and anastatic?
Although the initial results seem encouraging, not one of the society guidelines mention that we have to give this. But you can always individualize and give them this treatment.
And even if you start it, for how long you will give it? Even if you start for prophylaxis in certain group of patients, for how long you will give anastatic? Suppose you have to give ATD for 9 months to 12 months. So for how long you will give anastatic?
As I mentioned, the most toxicity is in the first 2 months. So most studies have been done in the first 2 months. You give them 2 months and then leave it.
And the second point, you said most of the viral hepatitis in case of these are hepatitis A and E. But in the initial marker you have used, that is for hepatitis B and that is for
because
C.
Hepatitis A and E in our country, you need to rule that out. With hepatitis B and C, these patients have been mentioned, but these patients are at increased risk of developing hepatotoxicity. Especially with ATT-induced hepatotoxicity, is much more common if patient is underlying. You need to do all viral markers, but I said hepatitis A and B because that's the commonest that in our country that you get.
But the positive organism is A and E, then the initial marker should include all the viral markers.
Yeah, ideally, yes, you have to do it. You know, it costs a lot of money to rule out diagnosis of hepatitis. You need to rule out EBV.
Dr. Harshad, we can continue the discussion over the lunch. So
Just one comment that for tuberculosis, I think everybody should take all the efforts to get a biopsy diagnosis. We are landing in trouble because we are not having a tissue diagnosis. And some of the pathologists are also not well versed whether it is Crohn's or TB. Nowadays, now we see more of Crohn's because now pathologists have been tuned to look at Crohn's. So request to all of you to just do not start ATT as a therapeutic trial, which we used to do only when we are very sure that we do it. And if we do it, we have to follow it very closely. Thank you for a lovely talk, Harshad.
I request now President Dr. Kamal Singh sir and Organizing Secretary Dr. Rohit Gupta to felicitate our speaker and the chairpersons of the talk.
बच्चा बनाएंगे नहीं है